And hi to all. My name is Carrie Hopkins-Isles, and I'm really pleased to have you here today through ICU DDR and a partnership with the University of the Balearic Islands in Spain. And we're so excited today to have building the capacity of the prevention workforce as both a standalone webinar and, as I said, also a partnership with our friends in Spain. So the way that we have it set up today, you will be able to hear our presenter and see her slides. And then throughout the presentation, you can type a question, should you have one, in the chat box. And you can either send it directly to ICU DDR, you'll see that option, or you can send it to the group. And either way, I'll be able to access that. And at the end, when Zili is all done, we'll be able to take some questions, and hopefully we'll have enough time to answer all your questions. But if not, I understand that she is willing to accept some emails from you afterwards as well. So that being said, I'm going to hand it over to Carmen, who's going to introduce our esteemed speaker. And thank you all for being here.
Thank you, Carrie. Good afternoon in Spain. Good morning in Ohio. Zili.
Hi.
I am Carmen Norte from the University of the Balearic Islands, Spain, and I am going to give this short presentation by our speaker, Zili Sloboda. Well, Zili, hi again from the confinement in Palma, and here we are at 5 p.m. First, Zili, I want to tell you that I am happy to see you again. I remember last time I saw you was in Vienna, and I was expecting to see you again at the end of this month in Washington, D.C. But, well, it's not possible because of Corona, but we can do it now in this shared closing session of the Prevention Expert course at the UAB. Well, we are very grateful that you accepted this invitation as a speaker under the title Building the Capacity of the Prevention Workforce. I want to give a special thanks to Carrie Hopkins, Deputy Director of ICU DDR, and also our good friend Michal Miowski of Charles University in Prague, President of ICU DDR, for having made this webinar possible. Many thanks. I am going right now to introduce you, Zili. I know Zili from maybe the last more than 2 decades. She's always leading in the field of prevention and always with her permanent smile. She never lost it. Thank you for this smile, Zili. Zili is very known in the field of prevention. She's the president of Applied Prevention Science International, was trained in medical sociology at the New York University and in mental health and epidemiology in the Johns Hopkins University, Bloomer School of Public Health. Her research has focused on substance use epidemiology services research and evaluation of treatment and prevention programs. Her current focus is on workforce development in the area of prevention and the relationship between training and the implementation of evidence-based prevention, intervention, and policies. This is a very new line of research in not only in Europe, in Americas, but over the world. She has served on the faculties of Johns Hopkins University, Bloomer School of Public Health, the University of Illinois School of Public Health, and until 2009, the University of Akron. Prior to this last position, and I think I met her in that moment, Dr. Sloboda worked for 12 years at the National Institute on Drug Abuse in several capacities. Finally, the NIDA, you know, maybe by this name. And finally, as the director of the Division of Epidemiology and Prevention Research. This division's focus was on the development and support of national research program in HIV, AIDS, epidemiology and prevention, and drug abuse epidemiology and prevention. And at the time had the responsibility for several large national epidemiologic and treatment data systems. While she was at NIDA, she and her staff organized the international epidemiology work, a group working in this field, and the International HIV Prevention Network. She was a founder of the US and EU Societies for Prevention Research and is well published in the area of drug abuse epidemiology and substance use prevention. Her most recent contribution to the prevention science literature is from the Spring-Head publisher series, Advancing the Science of Prevention. And currently in this series are Sloboda and Petras, Defining Prevention Science, 2014, Bosworth, Prevention Science in School Settings, Tisdale Bradley, 2017, Preventing Crime and Violence, and Sloboda, Petras, Robertson, and Hinkson, 2019, Prevention of Substance Use. Thank you, Zili, once again. I'm very happy to see you again. Whenever you want, please, the floor is yours.
Thank you very much, Carmen. Thank you very much, Carrie and John, for setting this up. I really appreciate it. Gives us an opportunity to get together, being away from each other physically for so long. I'd like to begin first by let's taking a moment to think about all of those who are suffering due to the COVID-19 pandemic and those who are working selflessly to care for those who are affected. So just take a moment before we begin. We're all very grateful to be here today, I think. I'm going to turn off my video and begin. I hope it works. I'm not technologically savvy, so bear with me. Okay, today I want to talk with you about how we can build the capacity of the prevention workforce to address not only substance use, but also other risky behaviors, and to establish an internationally recognized profession with its own knowledge base, skills, competencies, and ethics. As we go through my presentation, you will see that we have made great strides to meet this goal. However, there remain great challenges. I see that universities have a major role to play in meeting these challenges and will raise some of the ways I think they can move forward on the professionalization of prevention. Okay. Okay. I've been in the field, obviously, a long time, and every time we used to have a meeting about prevention, one of the first things would come up, and we debate about what is the definition of prevention. Sorry about that. I don't know what happened to move the screen. The United Nations Office on Drugs and Crime came up with a prevention definition that I think was developed by an international group, and so I think will be an accepted definition of prevention for everyone. I think that's really important that we have one that we agree on, and I wanted to underscore that the key words to me in this definition is the application of prevention science, health and safety, and improving socialization. It's been a long time since we've had a definition of prevention science. The term science of prevention actually appeared in the literature in 1993, but was not really defined until recently. The National Society for Prevention Research has been working on this, trying to come up with a definition. The National Prevention Science Coalition and our group, Applied Prevention Science, we finally came up with this definition just last year. I think it's important because we need to understand what prevention science does. It's not only important for determining effective interventions, but also to identify the determinants of behaviors that not only protect, but also put at risk individuals, families, and communities. Many of you who are researchers and scientists know that when you talk to a large group, sometimes people think when you're talking about science that they're only talking about research. However, we in the field know that besides the science base to many of our professions, like psychology or medicine, sociology, we really have two arms. Research, yes, but also practice. And in this graphic, I'm trying to depict the relationship strong relationship between research and practice in prevention science. Practitioners have vast experience in delivering interventions to a wide variety of groups. This information about how the intervention of policy is received by the target group, who was attentive, what problems arose during the intervention period, all are important for researchers to have. The improvement of prevention interventions is very much dependent on the equal interaction between practitioners and researchers. Prevention science is a multidisciplinary field that draws on epidemiology and the social, psychological, behavioral, medical, statistical, and neurological sciences. And the field really requires transdisciplinary teams in order to address problems that we have. You can see in this slide that basically prevention science is in its infancy. The Society for Prevention Research was established in 1991. As I mentioned, the term was first used by Coy et al. In 1993. The Society for Prevention Research in 2011 published the Standards for Knowledge. The EU Society for Prevention Research began in 2010, etc. And as I said, finally the term prevention science was defined in 2019. But prevention science in the field of prevention is growing and maturing profession. What does it take to establish a profession? It requires a systematic body of theory and knowledge, authority to define problems and their treatment, community sanctions to admit and train its members, ethical codes that stress an ideal of service to others, and a culture that includes the institutions necessary to carry out its functions. If you look at the evolution of the profession of medicine, I don't know if you can see the whole slide, but it took 2,000 years for it to be recognized as a profession internationally. So can we speed up this process? We have a lot in place already. We have a systematic body of theory, knowledge, skills, and competencies, and these have been acknowledged internationally, so we'll talk a little bit more about that in this presentation. We also have a code of ethics in place. We are working now on having authority to define problems and their treatment, and on having a credentialing and licensing to oversee the training that prevention professionals require to implement prevention interventions with children, adults, and communities. Tremendous progress has been made over the last few years to highlight the array of evidence-based prevention interventions and policies that are available for prevention professionals. So we've advanced our understanding of the processes leading up to the engagement in risky behaviors to better intervene in the initiation of use and progression from use to abuse and to substance use disorders. So we need to begin putting these into work for us. Let's start talking about some of these processes. We know that in most cases, substance use begins in late childhood and adolescence. We see in this slide that first-time dependence on alcohol, tobacco, and cannabis occurs in mid to late adolescence. We also know that substance use doesn't happen overnight. It's a process that includes many different pathways and is mostly driven by decisions influenced by internal biological factors and external environmental factors. We know that human beings go through stages of development in intellectual and language skills, cognitive, emotional, and psychological functioning, and social competency skills. These are all shaped by our cultural backgrounds. We also know that any disruption in the developmental growth process can make us vulnerable. And when we are confronted with emotional, physical, social stress, we may make maladaptive or poor behavioral choices. This is where prevention is important, to intervene early enough so as to prevent poor life decisions. Socialization is a process of transferring culturally acceptable attitudes, norms, and beliefs and behaviors, and to respond to cues in the appropriate way in our particular societies. It's a lifelong process, and individuals will be socialized by a large array. I should say individuals, we are socialized by a large array of different socializing agents. You know, our parents first, we move from home to school to our peer groups, our religious leaders. It's a whole array of processes that impact us. So the processes involved in socialization help to internalize social norms and values so that given a situation, we most often respond appropriately. The socialization process includes both behavioral interventions, for example, our parents guiding us on sharing with others or how to control our tempers when we are frustrated. The process also includes environmental interventions, for example, understanding that driving under the influence of a psychoactive substance is not accepted by our society. We need both types of interventions to be properly socialized. Temper tantrums in a school setting will not be tolerated, and understanding that drinking and then driving is not also not acceptable to our family and friends. Risk and protective factors defined here help us measure the threats that need to be addressed, but also the strengths that exist that help moderate or prevent the impact of the threats. The risk and protective factor approach, which was actually put forward in a publication by Hawkins and staff in 1992, has been really useful for the field of prevention. However, by looking at the issue of vulnerability, prevention interventions can target the underlying mechanism that makes us susceptible to engaging in high-risk behaviors such as psychoactive substance use. And we are now have been blessed in many ways with our contributions made by our neuroscience colleagues in understanding these processes of vulnerability. How do we put this all together in a way that guides our thinking about prevention? One way is to consider using the socialization process, what influences how we perceive and respond to the environments around us as they change with the transitions in life. How do we learn language, how to behave in specific situations, and how to become acceptable members of our families, our communities, and our societies? As we said earlier, we are born with our own biological and psychological characteristics. These shape how we behave and interact with our environments. In positive environments, we are enabled to achieve our developmental goals. In negative environments, we are not always successful in these achievements. We are born into both micro and macro level environments. The micro level environments consist of those that are more immediate or more proximal to us, such as our parents and families, and as I mentioned before, school, peers, and workplace. Beyond the micro level environment is the larger community and society. However, although ever present, our micro level environments buffer or temper and explain how we interact with our micro level environment until we are old enough and mature enough to engage in the micro level environment as independent individuals. The interactions between and across these environments are represented by the two-headed arrows marked 1, 2, and 3. They can be positive or they can be negative. So let's look a little bit more closely at these interactions. First, let's look at arrow 1 that represents the interaction between the micro level environment and the individual. Just as an example, a child is born with a difficult temperament and has difficulty adjusting to the world around him. He may be fussy, may demand a lot of attention. If his parents are not able to cope with him and is harsh with him, there's a strong possibility that he will continue to have problems dealing with new environments as he grows older, for instance, in school. However, if his parents had the parenting skills to appropriately and supportively manage this child, his potential for easier adjustment in these other settings is enhanced. Whoops. Okay. Let's look at that second arrow. This represents the interaction between the macro level environment and the individual. Let's take another child who is very close to his parents, who lives in a poor neighborhood with lots of rundown and empty houses. Unemployment is high, and during the day, young single men hang out on the streets drinking. They're in a gang. Our child must go past these men on his way to school every day. The young men tease the child and tell him that he will have to become a member of the gang. And to almost just to protect his parents, he may join the gang and eventually drop out of school. We know of many circumstances like that. The third arrow, 3, represents the interaction between the micro and the macro environment. This suggests that what happens in the macro environment will have an impact on the micro level environment. For instance, there are many situations whereby economic deprivation and unemployment impact parents and how they parent their children. Well, we can think of other types of example. A positive example would be one where regulations restricting the minimum age for purchasing alcohol sends a message to parents and young people that alcohol consumption is not healthy for children and adolescents and impacts perceptions of social approval of such use. We could also talk about how this pandemic has had an impact on families. So getting back to the idea, the concepts of risk and protection, how do these interactions work to explain these risk and protection? So risk is and protective factors are the interface between the individual, vulnerability, and the environment. So these factors can increase the risk or, as shown here, decrease the risk for involvement in problem behaviors. And we can see in a natural setting in these slides, these graphs represent outcomes from a study that was conducted by researchers at the University of Washington. They interviewed a cohort of 808 men and women from the time they were 10 years old to when they were 27 years old. And these figures show the relationship between behavioral inhibition, which means engaging in negative behaviors, the line at the bottom of the charts, and family management, the red and blue lines, in predicting alcohol use and dependence by age 27. The two charts here, one on the left is for alcohol abuse by age 27, and the right is alcohol dependence by age 27. The red line represents individuals in the study who came from families that had poor family management skills. And the blue line represents individuals who came from families with good management skills. What we see is that individuals with extreme behavior problems who grow up in positive family settings are more likely not to experience alcohol abuse or dependence in adulthood. But similar individuals growing up in negative family settings experience greater likelihood of having alcohol problems in adulthood. The protective influence of good family management on behavioral disinhibition is supported by this data. Here is some evidence of the effectiveness of an environmental influence, raising the minimum legal drinking age to 21 in the United States. This figure shows trends in alcohol and non-alcohol related traffic fatalities in the US before and after increasing the minimal age. The bottom line represents alcohol-related traffic fatalities. As you can see, alcohol-related fatalities decreased, while non-alcohol related fatalities increased after the law was passed by the federal government and states. Of course, environmental interventions such as changing laws are only as good as their enforcement. In such environmental interventions, enforcement is the means for establishing the new normative behavior that society wants to establish, and in the long term, the expectation that the law will be enforced maintains the behavior and norm over time. Digging deeper into our role as prevention professionals, we are looking at a chart now that shows that where we looked at the etiology model, which was pretty static, that human development itself is a very dynamic, obviously dynamic fashion. And what we see here is that there are multiple influences that affect us across our lifetime. There are many transitions that we go through that can put us at risk. These transitions may be due to normal maturation with associated physical, emotional, and cognitive changes. These changes will vary by gender and also by the degree to which earlier developmental benchmarks are achieved. Furthermore, how to respond to these changes are guided by family, community, and cultural factors. Other significant changes are related to changes in our physical environments. These involve moving from home and family to school, and in cases where schools are focused on developmental levels with elementary, middle, and high school, for instance, transitions may be challenging when moving from one school to another. So you have children who may be in the top grade students in one set of schools, but they move on to the next set, they become the entry-level newbies. Major transitions are from high school to college and or to work. In many cases, for the first time, individuals are away from their families and may have no supervision. And in some societies, movement from the family directly into a marriage situation and setting up their own family is also a transition period that could be stressful. Then, of course, there's social changes in our lives, changing peer relationships, dating, getting married, obtaining a new family, and having children. We know how challenging that is. Entering new job situations and cultures, and then finally retirement, loss of one spouse or partner, as well as loss of family and friends. So here we see the etiology model again, but now we see the processes by which our environment influences our responses to specific circumstances, settings, and life choices through our beliefs, attitudes, and skills to make decisions regarding our behaviors. Our work as prevention professionals then is to identify where we can intervene to affect these decisions. The stars in the graphic identify potential points for intervention. The micro level environments of family, school, and workplace, and the macro level environments. Then we as prevention professionals can interact with the individual directly or with the individual's micro and macro level environments. As we noted in the etiology model, both approaches impact behavior and both approaches are needed to make a difference in a community. Therefore, prevention professionals may train key socialization agents from the microenvironment, like parents and teachers, to help them improve parenting, family management, and classroom management. But prevention professionals themselves become socialization agents by directly engaging in the socialization process through, say, a school curriculum. They help individuals understand expectations in different social and emotional contexts, practice new behaviors, and collect and interpret information to make informed decisions about their behaviors. Furthermore, through macro-level environmental interventions, prevention professionals can create environments that help to reinforce positive decisions and positive decision-making. Some of these involve changing policies or laws, regulating access to substances, for instance, controlling their use in public places, raising taxes on purchasing, and other environmental actions. It should be clear by now, I hope, that in any community, we need both micro and macro level environmental interventions. Each reinforces and supports the other, and they all need to be evidence-based. So now I'm going to switch to talking about evidence-based prevention, since this is a new concept in our field. What do we mean by evidence-based? Drawing from the definition of the Evidence-Based Practice Institute of the University of Washington, there are two key aspects of this definition. Systematic decision-making using scientific evidence that is associated with improved or positive outcomes, and reliance on data collected through rigorous experimental research. So what makes an intervention evidence-based? Key to an intervention or policy being evidence-based is having strong, significant outcomes using a rigorous research design that compares the intervention group to a control group made up of those with comparable characteristics who did not receive the intervention. And we have here a list of the strongest, most rigorous of experimental designs. The randomized controlled trials, experimental designs with comparison group and time series analysis. And these are particularly useful when we're talking about policy changes. To date, the only group that has reviewed all published and unpublished research that examines the outcomes of substance use prevention interventions and policies has been the staff of the United Nations on Drugs and Crimes. And they did this with representation from over 80 countries involving prevention professionals who are involved in policy, who are involved in research and in practice. Hundreds of research manuscripts were reviewed and assessed. And please note at the bottom of the screen, if you aren't familiar with the International Standards on Drug Use Prevention, the URL for assessing that document. I'll keep that on the screen for a minute, or a couple of seconds, sorry. Okay, this is very complex, difficult chart to read, but I think what stands out to you is what the summary of this review of the literature, the research literature. Across the top, we have ages, the age groups from prenatal and infancy through to adulthood, and along the side, the left side, we have the micro and macro level environments that we were talking about before. So we have interventions that have been found to be evidence-based for addressing family, school, community, workplace, and the health sector. There are so many advantages to implementing evidence-based interventions, and they're listed there here, but the most striking is that they generally have the best outcomes. But there are also some barriers that we know of that when we talk about evidence-based interventions are brought up all the time, having to do with the implementation of these interventions. So just take a moment and look at this list and just to make note to yourself, what do you think about them? And what do you think would be the most challenging? And this may be a topic for later if you wish, but just give us some thought. Okay. So what do prevention professionals need to implement evidence-based prevention interventions? First, they need to understand prevention science and why it is foundational to evidence-based prevention interventions. Second, prevention professionals need to understand in what ways prevention science is applied, excuse me, to evidence-based interventions that address families, that are used in schools and the workplace and in our micro-level environment and through all forms of media. But also, as we saw in the etiology model, comprehensive prevention interventions are needed to address multiple community needs. Therefore, prevention professionals also need to know how to build and support implementation systems to support these many prevention interventions. And excuse me, sorry. This information requires a systematically developed training program for prevention professionals. With funding from the United States Department of State, we have begun pulling this knowledge together. APSI coordinated with expert scientists to develop the Universal Prevention Curriculum, which many of you are familiar with. We designed this to capture the results of substance use prevention research and incorporate this into a comprehensive training program. APSI now has an education group, a center that we're updating and adapting UPC to fit a variety of platforms to make it available to working professionals in the prevention field. And who makes up the prevention workforce? And I think this is another challenge to us. There are those who self-identify as prevention professionals. They generally have different educational training and prevention experiences. Then there are those who are doing prevention-related work, but who do not self-identify as prevention professionals. And we work with them every day. There are social workers, law enforcement officers, teachers. So one of the challenges we have is how do we reach both groups so they share the same knowledge, skills, competencies, and ethics to form the prevention workforce and to professionalize the field of prevention. But even more challenging is how do we build a culture of prevention to support and sustain the field of prevention over time? We have some institutions that are already in place to achieve this goal, but more is noted, as I noted below, but more is needed. And now this is when we begin talking about the role of universities. What is the role that universities can play in influencing prevention as a profession? They can offer courses on prevention science as degree programs, or as courses that students can take as a minor focus or as an elective. They can also offer courses as part of a continuing education program so that prevention professionals can update their knowledge and skills, and those who are new to the field can gain knowledge and skills that they need. Also, universities can offer 2 tracks in prevention, one for those who want to conduct prevention research and those who want to implement prevention interventions. And my dream has been to have a degree program where everybody goes through the same, gets the same knowledge base, but then they can track to research and they can track to practice. And I think that this reinforces the earlier slide that I have with practice, prevention science, having the 2 arms of practice and research. This would really solidify that concept, I think. Furthermore, universities as a consortium can develop a prevention research agenda. We really need that. And if you go through the international standards on substance use prevention, drug use prevention, sorry, you can see that there are gaps. The field has come a long way, yes, but these gaps still are there. There's gaps in epidemiology and etiology. There is a need to develop new interventions and prevention strategies, and there's definitely a need to evaluate new as well as existing interventions, particularly in different settings as they're introduced into different settings. So I leave you with this slide. What are our next steps? Something for you all to think about in the future. I want to thank you for your time today. Please note on this slide that I have my email address, Zili Sloboda at apsintl.org. I do respond to emails. And also, I wanted to, those of you who are interested in learning more about our training, I wanted to refer you to our website, www.apsintl.org. Thank you very much. Carrie?
Hi, thank you. That was excellent. And let me get back on here. Okay, so I see we have a lot of attendees. Thank you for being here once again. And this is your opportunity for questions. So if you would like to type anything in the chat box, this would be a time to do that. And we can have some discussion. So if you have a question or maybe a comment, Zili did ask for us to kind of give some thought to some of her topics there. So far, we don't have any questions. You were just too comprehensive and clear.
Yeah, right.
That has to be it.
Well, if anybody has any questions, again, they have my email address, and be happy to hear them.
So I guess from my perspective, I'm on the more treatment side of things. Do you feel that there are ways that the prevention and treatment side of addictions can work together more
Absolutely.
strongly?
Absolutely. In fact, the idea of the ICU-DDR and the internet, the ISOP, actually were my ideas of bringing people together, treatment and prevention. Because one of the slides I show is from the National Institutes of Medicine, where they show an array of services. In every community, we really need to have prevention services through to recovery services. They need to be integrated. They also I think that the etiology model that sort of, this is brand new, these concepts, I think apply to treatment as well. And I think that, I'd like to talk more about how I see that is being integrated into treatment process. I mean, we had the ASI, if you recall. I don't know if groups are still using the ASI, but that sort of captures a lot of the components that are in the etiology model. So yeah, I definitely feel that there's a need for that. Also, who are most at risk? Children of substance users. Having parenting programs in treatment not only help, the one study that I know of, research study, did help retention rates to parents when they were learning, when they were having a parenting skills program, they stayed in treatment longer. So I think that makes a big difference too. So I see that the need to integrate is very important.
So we do have a few questions coming in now. Any comment about decision makers as barriers for implementation of prevention?
Oh, do we really want to go down there? I mean, to be honest with you, I'm really concerned about what happens after this pandemic. We've been doing a lot of webinars with prevention professionals in the United States, and we're sort of literally a captured audience. But many of them are concerned about their jobs when this is all over. Many of them work for states, many of them work for communities. So I don't know if the funding is going to be there. This is why I think the culture of prevention is really important. I think this pandemic really underscores the importance of prevention. As I tell my husband, before, when I used to tell people I was an epidemiologist, they thought, oh, you study skin disease. Now I think people understand what epidemiology is.
Oh, goodness.
So, yeah, I think this is a challenge for all of us.
How do we involve the universities in prevention tasks?
Well, let's just give you another little aside thing, my experience. When I was at NIDA, and there was upheaval in one of the African countries, I won't talk about which one it was, the only contact we had was with the university. They kept going. And I think the university sort of underestimate their power in a community, in a society. And I love the idea of the consortium, because I think the consortium brings people together, and I think we can address these kinds of things. I think that getting our heads together and thinking about how we can make a difference, how can we make the changes, and I think the whole idea of professionalizing our fields more, both treatment as well as prevention, can it be supported by the universities? And I think universities have more leverage with policymakers, for instance. So I think we need to develop a plan. I said not only a research agenda, but I think we need a plan to move this out. And I think universities have a very powerful role in that.
Great. How to use ICT in prevention, since young people are immersed in them?
All right, forgive my age is kicking in here. ICT is?
I don't know, so I'd have to, I guess my age is too. We'll have to ask whoever to, Susanna, I believe, asked that question. So can you illuminate what ICT is, and then we will respond? I think one of the lacks or still unachieved items is advocacy and introducing prevention science in the public institutions. How do you think this should be addressed? Thank you.
Yes, absolutely. And I think what I said about the universities is certainly important. when I was at NIDA, I used to have to go to Congress, to hearings, etc., to get messages across. And at that time, I was in charge of HIV. That was a huge challenge to get support for HIV work. But we were able to do that because it began affecting so many people. I think we have to educate our policymakers, maybe locally is a good start. We're part of the UPC training is trying to get prevention practitioners to develop an advocacy talk, the elevator talk, to talk about prevention science, because I think like education, prevention has not received the kudos and the support that it needs universally. So I think this is a challenge we have. I don't have an easy answer. Again, I think more heads are better than one on addressing these issues. And again, I think we have the forum here to do those kinds of things.
Yep.
Thank you for those questions.
Returning to the earlier question, ICT or networks or technology. So I'm assuming probably social media and things of that.
Yes, actually, there are a number of interventions using social media that are in the pipeline that I'm excited about. I've been talking to several people that are working on those right now. Getting that published in the next, that's the problem. Of course, nothing is fast. They have to do the research and then they have to publish it. And so I think this is definitely going to be something we will be highlighting in the next couple of years. I think even we're seeing more on community interventions. We're seeing more in the literature on interventions in the entertainment venue. Of course, all that's changing now. But there are some really good things that will be coming out, and I think we'll be adding that to the international standards, and because that's being updated every couple of years because of that. The new research is coming out.
So we have a really great question about how do we work with policymakers to incorporate prevention based on evidence? Their goals are short term and the results of prevention are in the future.
Yes, absolutely. I think that one of the things that we can do, and I believe me, this has been my challenge too, is that we not only do we have the long-term effects of the evidence-based interventions, but we also have intermediate, more short-term outcomes that I think we don't highlight enough when we talk to policymakers, that we can see 1 or 2 years after, or even several months after, the children tend to have different attitudes about school. For instance, they bond more with school. They tend to be, therefore, stay in school. So even though we might be addressing substance use in the long term, we are having other kinds of powerful effects in the short term. And we need to focus on those, I think. I think you're absolutely right.
How do we build the culture of prevention when many of our universities don't have prevention science programs?
The reason why I raised the whole idea of culture prevention, we sort of, it's like a concept that we talk about, but we really haven't defined it. And I had the privilege of being asked by the editors of Prevention Science Journal to write a commentary on this, and it really made me think thinking about it. So I think we need to, and I think the universities have a good role in doing that, is what are we talking about in the culture of prevention? And I don't know why we need to pull in our public health people, perhaps, in talking about that. I think that universities, there are a number of challenges in universities to integrate a prevention science program. Many of the faculty, maybe psychology, sociology, they all feel that they know it right now, and they feel that they are already doing that to some extent. And I think it's because we have not really defined prevention science and all the components as I laid out today for universities. But I think we're going to be as I said, we have to form teams, transdisciplinary teams. And I think you can have a prevention science program in a university by pulling different departments together, for instance. A colleague of ours, Ron Prince, is doing that at the University of South Carolina. And he has a translational PhD program where he's brought up different departments, and they have doctoral students, and they take courses together. So he's developing that prevention base. I think we have to be creative in doing that. And I think each university differs a lot in terms of their embrace of prevention science.
Thank you. Another question here in the chat is, what are some challenges you see for the future of prevention science after COVID-19?
Wow. I see lots of challenges. On the upside, I think that prevention practitioners, particularly many of them that we've been working with through our webinars, are just excited about this new information. They're able to step back from doing their 24/7 job to really sort of getting back to basics and learning about new concepts in the field. I don't have an answer to this question. I'm sort of overwhelmed sometimes thinking about it, but I think prevention professionals are really going to be needed. They need it now.
Right.
And I think that's why the social media has been important. In some of our colleagues have been doing work in working with families that are stressed. So I don't know. I think we have to be thinking outside the box to get us started again. This is not only true for prevention, but this is true for treatment. We may be overwhelmed when we get through this, but my concern is, where's funding going to be coming from? I mean, one of the state universities here that I've been working with that has a doctoral program in prevention science, they're concerned that they're going to have to take pay cuts because they won't be having students coming in. So I think there are lots of challenges that we're going to be confronting.
Yeah. Well, I think those were all the questions that we received. I think we strained your brain as much as possible there, got you lots of challenges. Is there anything that you'd like to say before we sign off? We have a couple minutes.
Just to thank you for not only being here today, but also for your strong interest in prevention. And I think we have to this is a great way for us to work together on some issues. And I think we just have to pull together.
Yes. And I thank you all for your partnership as well. And if you are interested in other topics, both treatment and prevention related, I saw a few questions on advocacy, and we had a webinar, and we'll be having another webinar free for all of you in the future. I think it's going to be at the beginning of June, but you're welcome to check out icuddr.org for our websites, our webinars. And as Zili mentioned, we also have ISSUP, issup.net, and they have a lot of great resources. They pulled together their webinars as well as other webinars on the topics, and you can access them from there. So with that said, I think we can say goodbye. Did you have something to say?
Yeah, if it were possible, would it be possible to make of those who are interested this kind of photo of all the participants, like
right.
tiny jigsaw?
But we have to see Zili also.
Okay.
Zili, before you leave.
Okay, let me see if I can bring that up again.
And the spectators, if they are up for, if we can make them able to join and make the picture.
Oh,
well, unfortunately,
my host stopped my video, so.
Unfortunately, let's see, our participants are not able to because they are in webinar.
Okay. Well, maybe the panelists then.
Yes.
But Zili is not here. Where are you, Zili? I can see you.
I don't know.
I made
Good
her.
question. There we go.
There you are. Zili, can you tell me your email again? I'm going to type it in the chat. I'm
Sure.
being asked.
Zili dot Sloboda, SLOBODA at APSINTL.org.
APS.
Applied Prevention Science, INTL.
Okay,
.org.
got it. Okay. Oh, Carmen, where'd you go?
I opened the window.
Okay, wait, I'm trying to do it where the camera's not in my face while I take it. All right, cheese.
Jeez.
Yeah, thanks a lot.
All right, thank you
Thank you,
all.
guys. Thank you.
Care.
You made it so much easier.
Stay safe.
I enjoy very much.
Well, it's good to see you guys.
Yes.
Hopefully we'll see each other in Lisbon in October.
In October,
Maybe.
maybe.
So,
Bye.
Bye bye. Thanks for everything. Bye.
Bye. Thank you, Kari.